Good evening. My name is Rod Dawson. You may have heard of some people say that pediatrics are just small adults. Well, I can tell you that is the furthest thing from the truth. We're going to talk today a little bit about how the anatomy and physiology differs from that of an adult versus a pediatric. Probably one of the biggest difference between the pediatric and adult patients are their airway. Children have much smaller noses and mouths versus the adult. In a child, more space is taken up by the tongue. The child's trachea is also narrow and looks somewhat like an hourglass. As you see here, the adult airway runs parallel with each other. The pediatric airway actually looks like an hourglass and becomes narrow at one point. That can be a major issue with pediatric airway because if the patient's airway starts to swell or there's mucus, that patient can go into respiratory arrest very easily. And we know that respiratory distress leads to a respiratory arrest in the pediatric patients. Another problem with their airway is the large size of the pediatric head compared to that of an adult. Infants younger than 6 to 7 months old also cannot support their own head. We know that when a pediatric patient lays supine or on their back, the best position for their head is in the neutral position. When they're laying without assistance or unconscious, you can see in this diagram that because of the large head, it actually puts the patient in a flexed position and can cut off their airway. Let's talk a little bit about the difference between the lungs and the chest area or thoracic area of an adult versus peds. Ribs in the pediatric patient are much more pliable and horizontal. And we know that the rib cage actually protects all of the organs on the inside of the thoracic cavity. If they're very pliable, this does not offer the protection that an adult patient would have. And this is due to the calcification of all of those ribs once you get older. Basically, those ribs are made up of cartilage when you're a pediatric patient. We have to also remember that the lungs are more fragile because they're still developing in a pediatric patient. When a pediatric patient experiences blunt force trauma, that force is communicated through the rib cage and actually into the organ itself, which creates much more damage. So it's also normal for a pediatric patient to use their abdomen to inhale. You can actually watch their abdomen go up and down as they breathe. That is not normal for an adult patient. They do not use their abdomen. Breathing is also much different in an adult patient as it is with a pediatric patient. A normal adult rate is about 10 to 20 times a minute. A pediatric respiratory rate can be anywhere from 20 to 60 times a minute. Infants and children less than 5 years old breathe at a rate of about 2 to 3 times faster than an adult. The cardiovascular system in the pediatric patient is also different from that of an adult. Bradycardia is a late sign of hypoxia for infants and children. For newborns, bradycardia is the initial response to hypoxia or to cold temperatures. When we start talking about hypotension for a trauma patient, a pediatric trauma patient, normally hypotension will not develop until greater than 30% of the blood volume is lost. So here is the difference between pediatric shock and adult shock. In adult hypovolemic shock, you'll actually see the blood pressure start to trend down. In the pediatric patient, they're very good at maintaining their blood pressure until the very end. So you cannot use blood pressure as a definitive vital sign for a shocky pediatric patient. So abdominals, muscles are also different in the pediatric patient compared to the adult. If you think about it, the abdomen in the pediatric patient is not developed yet. Those muscles are weak, and the muscles of the abdomen protect all of the organs inside of the abdomen. And you also have to think about it, the liver and spleen are more exposed and less protected in the pediatric patient. Once again, in a trauma situation, that blunt force is communicated directly into that organ, which can cause organ damage. Bones are different in the pediatric patient compared to the adult. They've not completely calcified, and they're much more pliable, which can actually lead to bending or splintering of the bone in the pediatric patient. Once again, the metabolic rate is also a consideration for the pediatric versus the adult. Pediatric patients are at significant risk for acute hypoglycemia or low blood sugar. Because their metabolic rate is going so fast, they're using up oxygen and they're also using up glucose. So if you have a child that is in extremis or sick, they can use both of those, the oxygen and the glucose, up very fast. So you have to watch that very closely. We give oxygen to pediatric patients much more frequently and often compared to the adult population. Some of the other things that we may want to consider with the pediatric patients versus the adult are some of the instruments and tools that we use to provide treatment. IV catheters, for example. The pediatric patients have very small veins that we introduce a IV needle into versus the adult. So the IV catheters are going to be much smaller versus the adults. Also are the oxygen delivery devices. We give much more volume to an adult patient of oxygen versus the pediatric patient. The pediatric patient's lungs are not as well developed as well, so we have to be very careful about the amount of pressure that we use when we deliver oxygen to the pediatric patient. Providing too much pressure is called barotrauma. Thank you so much for listening to this presentation about a couple of differences between the adult and the pediatric population. And remember, pediatrics are not small adults.